panelists. I just wanted to welcome everybody. Please introduce yourself on the chat and give your questions on the question and answer icon. And this is the series of our COVID related topics on Sunday, which is 8 p.m. in Pakistan and 11 a.m. in Eastern time zone. And that is continuing. We have two other webinars on Saturday. One is focused on nursing for COVID and critical care issues. That is on, at, I think, Pakistan's 6:30 p.m. or 7 p.m. And then the second one is the critical care case discussions with different institutions, and that is at 11:30, which is Pakistan's 8:30. So every weekend we have three webinars. So just to announce that. And so with that, I will request Fizza to take over. Thank you.
Assalamu alaikum, everyone. Thank you, Dr. Shahid, for the kind introduction. And I'm practicing here in Calgary, Alberta for more than 15 years. And my background is also from family medicine. On behalf of APPNA MERIT, I would like to welcome all the panelists as well as our great speaker here today. It's a very nice topic today of telemedicine and role of family physicians. As you know, family physicians are the backbone of any health system. The world has changed in the past few months in this pandemic, and telemedicine has a big role now as the world is changing. So I would like to introduce our speaker today, Dr. Hina Jawaid. She is MRCS from UK, MSc UK, MRCGP from UK, and she is Assistant Professor in Family Medicine, University of Health Sciences, Lahore. So welcome, Dr. Hina Jawaid. We would be happy to learn from you. So you can introduce yourself now and tell us more about yourself, and you can start your talk. Dr. Hina Jawaid.
I hope everyone, thank you very much for the kind introduction and for giving me an opportunity to use this forum to present my work. I hope everyone can see me and my slide as well and hear me as well.
Yes, we can.
Great. Right. So my topic is University of Health Sciences Telemedicine Center and the role of family physicians. Let's move on. I have already been introduced by Dr. Fizza. I'm a Dow graduate, followed by a membership from the Royal College of Surgeons, then MSc in Surgical Sciences from University College London. And the final qualification is MRCGP from Royal College of General Practitioners, London. Currently, I'm working as an assistant professor in the Department of Family Medicine at University of Health Sciences, Lahore. This is my place of work. That's the front of the building. Right. I'll go through the timeline just to give you a brief summary of what we have been engaged in. On the 18th of March, the university started its telemedicine center. So it was inaugurated on the 18th of March. About a month later, we carried out a patient survey. It was just a random pick. We made calls to patients who had called our telemedicine center earlier and took feedback from them. I will be talking about it in detail later. And that was the turning point for us, where we thought we need to make some changes in the way we are carrying out our services. So on the 13th of April, we arranged a meeting with the Governor of Punjab. The reason being, he's the Chancellor of all the universities of the province, and also this project was his initiation. So it was his idea to start the telemedicine center and chose our university. On the 16th of April, we decided to have the family physicians as the supervisors of that telemedicine center so that they can deal with the common ailments more appropriately. And I'll discuss the reasons why this happened. On the 5th of May, we carried out an online survey taking feedback from the family physicians who were acting as supervisors for the 8-hour shifts in a 24-hour period. There were 3 shifts in 24 hours. So we took feedback from them. It comprised of 10 questions, and I'll share a couple of slides about what they said, what were their answers. In May, we also started working on a few research projects. They are underway at the moment, and I will be talking about them later on this forum when I have got more data about them. As I said, a couple of them are in the process. On the 9th of July, we decided to kind of formally start patient advocacy. We were doing it in one way or another, but then we decided as the family physicians to act as a mediator between the patient and the government. So recommendations given to the government through our telemedicine center, identifying gaps in the healthcare system and what we can do to improve it. Right, so the beginning was on the 18th of March 2020, University of Health Sciences in Lahore became one of the first institutions in Punjab to start the telemedicine center, which was mainly developed to serve the COVID-19 pandemic, people affected due to that. So the main reason for initiation was the COVID-19 pandemic. We were given equipment and stuff for telephone consultations and video consultations. These are the photos. These are the photos from the inauguration. You can see our worthy Vice Chancellor, Professor Javed Akram, along with the Governor of Punjab, Chaudhry Mohammad Sarwar in this. This is a photo of our video call section where we receive calls from the patients. And we have got a larger audio call area. You can see the volunteer doctors. These are junior doctors, fresh graduates, along with a supervising family physician. While this was happening, we were in the process of developing an online course. Professor Nasir Shah, he's one of the panelists. He was actively involved in developing this online course. This was basically to provide up-to-date information for our junior doctors. When we were planning this course, we thought that we may not get more than about 10,000 doctors, but to our surprise, about 42,000 doctors enrolled in this and completed the course. We had to stop this course on the 22nd of May 2020 due to financial constraints. And I'm sure Dr. Nasir Shah will be more than happy to share the details of how across the globe, which countries were they from when they did the online course. It consisted of information about the COVID-19 because we know the situations were evolving, symptoms were changing. So this was developed as a part of it. Clinical recommendations as given by the government were changing what treatments to be and not to be given. So we were constantly updating our online course. This is a screen telling us about the website that the patients have to click on. It's called doctors247.online. And when the patient go on this page, on the web page, they've got 4 options at the bottom where they can click and get linked to a doctor through a video call. And I would like to mention here that all consultations, both audio and video, are completely free of charge. We don't cost, it doesn't cost anything. The patient feedback that we carried out from in the end of March, it consisted of about 17 audio calls, 6 video consultation. The age range of patients were between 16 to 65 years. Majority were males, 6 were females, and they were about 9 cities across 3 provinces. So we had people from Punjab, Sindh, and KP. About 20 were satisfied, but 2 were unsatisfied. And it was these unsatisfied people that kind of prompted us to intervene and do something. And I can share what the unsatisfaction was due to. One of the patient calls for, with the result of blood cultures for Salmonella typhi, the doctor who was dealing with it felt he wasn't in the position to offer the treatment. And another patient called for allergic chronic rhinitis. One of the patients did not engage with us in answering the questions that we had in terms of obtaining the feedback. So that was just to mention. Once we obtained the results of the feedback, we decided to do something, and by we mean the family medicine department. We actually arranged a meeting with our Vice Chancellor initially, and then the Governor of Punjab. I know you might have difficulty reading the print, but this is a one-pager with 4-point agenda, which we took to the Governor House and explained him, detailing what family medicine is, what primary healthcare services are, and how we can improve the telemedicine services that UHS is offering. The figures here are mentioned are different from the one I mentioned earlier, because this document is dated from from April, 13th of April. So we had about roughly 30,000 doctors enrolled at that time. The last point was mainly to protect our population from healthcare fraud, the quackery. And what we suggested to the Governor Sahab was any NGO or a company or any institution who would like to register the telemedicine center, they must go through Punjab Healthcare Commission and provide a list of qualified stroke trained family practitioners in order to avoid quackery and to safeguard people interest. So we've set an example by with the family physicians taking the lead. We didn't have many people in the beginning to start off. I mean, 5 months down the line now, when I look back, we were a very small team. Only 2 FCPS from the College of Physicians and Surgeons. I was the MRCGP, and we had about 10 MCPS and MRCGP international degree holders with us. Luckily, in December, we had started our faculty development program, and we were able to involve a lot of our participants from that program. And I would like to thank Fatma Memorial Hospital for their massive support, their family medicine department, for their massive support that they've offered up until now. Moving on, when we carried out the online survey, we collected data from 5th May to 12th May, and I would like to share the results of 2 of the questions we asked them. What percentage of COVID calls are you receiving? And you can see the larger chunk, about 63% of the doctors, they said less than 20% of calls were COVID related at that time, from 5th May to 12th May. Following on the next question, what percentage of non-COVID calls are you receiving? And you can see from this pie diagram, about 50% said up to 80% of the calls are non-COVID. Again, the reason for sharing these slides is to emphasize on the need of a primary healthcare system, or having a general practitioner stroke family physician as the first port of call. It's always nice to get acknowledged by the institution you work in. So this is a photo taken from a 2-pager document released by the University of Health Sciences following a meeting between the university's faculty, vice chancellor, and the Governor House team. And it stated it's what we have been working on. They highlighted the role of our department, our initiative, and the fact that we emphasized on providing quality services to our population. And I think it goes without saying that general practice is the easiest thing to do badly, hardest thing to do well. And I think all the general practitioners, they know how hard it is to provide quality services in a community-based setting. Now, what COVID has taught us, what this 5-month experience has taught us, it goes without saying, and I think I'm repeating what we already know, that a well-established and a functioning primary healthcare system is what is needed in our country. And telemedicine itself allows access to cost-effective quality care to all, and particularly in remote areas. We do need trained family physicians. I think we have proven ourselves. We have demonstrated it through telemedicine. That's what we need. And also as educators, when our faculty development program participants were holding the position as supervisors, and the feedbacks we have got about them, it has given a lot of spotlight to family medicine. A lot of fresh graduates said they now know what family medicine is. They didn't know about it. they like the way our doctors consult and take and ask questions from the patients, particularly during the audio consultation, because it's even harder to assess patient and to provide consultation and management when patient is not in front of you. So there is an appetite among the young doctors for taking family medicine as a career, which is a positive thing for us. This is one of my last people that have been part of this kind of adventure for us. It was a risk that we took, and I'm proud to share that we had some amazing experiences and feedback from a lot of people, and support, obviously. And this is my last slide, laying out some questions for panel discussion, what we have kind of extracted from our experience. Is telemedicine service, the service that's established during the pandemic, can it be made sustainable in both public and private sectors? And how can private sector share the workload, considering a majority of the primary care services are provided by the private sector? Do we think implementation of telemedicine system can be a way forward to avoid self-referrals to specialists and avoid bypassing primary care facilities in both urban and rural settings? And in terms of academics, how postgrad teachings in family medicine changed during the COVID times? And the last is, again, a very important point, in terms of paper-based records and electronic records. Our record system is currently paper-based. How can we make it more effective? How can we ensure patient confidentiality? Thank you for listening, and I'll be happy to take any questions from now on.
Thank you, Dr. Hina Jawaid. Was great presentation by you, and introducing family medicine in Pakistan. It's a great initiative, and it's good to hear that lots of new students and fresh graduates are interested in family medicine, and it depends how we are going to showcase our work in Pakistan and engage more and more students, and especially final year students and new graduates, to come into family medicine. And you know, family medicine is the backbone, and we need more qualified healthcare practitioners in Pakistan in family practice. So we have a group of panelists today, a great group of panelists, and I would like to invite Professor Nasir Shah is among us, and everybody knows him. And here in Canada, we know Dr. Nasir because lots of Pakistani doctors from Canada are going to Fatma Memorial.
He stepped out.
He's not there?
Is he? I think he may have stepped out or having some problem with the internet.
Sure. So, so the next one is Dr. Ijaz Ahmed Khan, if he's with us. Dr. Ijaz.
Hey, Assalamu alaikum. Yes, I am with you.
Assalamu alaikum. So Dr. Ijaz, would you like to introduce yourself? I know you're Associate Professor of Public Health, Health Services Academy, Islamabad, Pakistan. So please say a few words about yourself, and then Dr. Hina Jawaid has asked a few questions. So, and you have any comments, and would you like to share?
Yes, thank you very much. As you already introduced me, I have around 20 years of experience in academics and research, particularly in primary healthcare, public health, and recently we have been asked to start a family medicine program at our institute, which is now is a functional university. So I think all of these questions that Dr. Hina has posed, they are quite valid. And I had one more question in my mind, in addition to these four ones that Dr. Hina has posed, that who will be or should be the regulator, or who will be doing the accreditation of telemedicine, who will be checking the quality of services, the quality of care through telemedicine, which body should be that? Either it should be CPSP in Pakistan, or it should be PMDC. So this is another question which came to my mind. For first question, that the telemedicine service established during the pandemic can be made sustainable in public and private. So I think it's very important, because the initiatives, most of the initiatives in countries like us, where we are the developing countries, we take up, there are examples from the past, since earthquake of 2005, and then every year we have those floods. A number of disasters, man-made and as well as the natural disasters, have struck Pakistan, and a number of initiatives have been taken, but with time they just whittle off, and they are not sustainable. Telemedicine has been in Pakistan for quite a while, like in KP, and there have been a lot of work on it. But I think now when we are talking about pandemics and emerging infections throughout the world, and people, and the way the COVID has struck the whole world, and the hospitals have, people are avoiding hospital contacts, and most of the time where the healthcare professionals, they come in contact with the infection, and most of the patients are asymptomatic. It's important, I think, that here the telemedicine puts a barrier between infection and the death. So that's why this telemedicine becomes important when we talk about infectious disease, and blending it with the family medicine is a wonderful idea, because this is the first level of contact of patient with the health system. Now, telemedicine perhaps has an opportunity to cash where it can develop itself in Pakistan, and it can be pursued with the government and the private sector both, because I think there's a lot of opportunity in the public sector and as well as in the private sector in Pakistan to invest in telemedicine for the coming years. We have seen that there are a number of initiatives have been taken throughout Pakistan in telemedicine, especially in the private sector. Now, the public sector universities, they are also thinking, and they are also taking initiatives in bringing in telemedicine in public sector hospitals and academia. So maybe public-private partnership, and because you see that public sector, when they will be offering telemedicine, it would be free of cost, but not for the private sector. So it has to be subsidized perhaps through the health card scheme, Prime Minister's health card scheme, which is already subsidizing for the poor. So that could help there. But again, here one point would come that I would stress, that the quality of healthcare through telemedicine should be monitored, and we should discuss which could be that body. Is it going to be an existing body which is going to monitor it, or we need some college of telemedicine or something like that, or which could be, because PMDC has to do a lot of things, and there have been a lot of bumps in the recent years on the road for PMDC. So that also need to be discussed. Thank you.
Thank you, Dr. Ijaz. And I will move to our next panelist, Dr. Tahira Salim. She's a MBBS, MRCGP UK, GP partner, 14 years experience in the UK, occupational health physician. Welcome, Dr. Tahira Salim. Would you like to tell us more about yourself? And then there's a second question in the panel discussion if you would like to answer that question. Thank you.
Yeah. Okay. Assalamu alaikum, everybody. Can you hear me?
Yes.
I don't know whether you guys can see me or not, because I can't see myself.
No, we can see you.
You can see me. Okay.
Yeah.
Right. So I'm originally from Pakistan. I'm from Karachi. I'm a Thai graduate as well. And I completed my degree back in 2002. And then I did my internship in Aachen Hospital, and then came to UK. So I've been working here as a general practitioner for quite some time now. So I completed my general practice training back in 2010, and then did a diploma in occupational medicine. So I mean, it's really interesting and quite exciting and heartwarming to hear what Dr. Jawaid has told us today. I had my first taste of family medicine while I was doing my internship at Aachen University, and I did a 3 months rotation there, and that is what really got me interested. Along with that, my father was a GP as well. So again, I mean, he was a Dow graduate, and like you guys have touched upon the subject, that we've got lots of GPs in Pakistan, but actually family medicine is a very undervalued specialty, I think. Even out here in UK, I have to say that the way general practice is perceived is not the same as other specialities. There's quite a again the same sort of concept that, oh well, you know, you're just a GP, and that's where I always emphasize that for a backbone of the healthcare system, for that to work well, one can't just be a GP. And I think that is this point really gets me cross sometimes. So I mean, coming back to your questions here, the second one you've asked me to comment on, do you think implementation of telemedicine systems can be a way forward to avoid self-referrals to specialists and bypassing primary care facilities in both urban and rural settings? I would definitely say, you know, this is the way forward. We certainly out here in UK, I can give you some, you know, feedback sort of stuff from where I work. Telephone triage is a big thing here as well in UK. So even before COVID struck us, we do telephone appointments as part of our clinics, 3 or 4 telephone appointments, and those will involve quite stuff that can easily be done over the telephone. So you can have like medication reviews, you can have chronic disease reviews like hypertension, COPD, and all of that. You can deal with mental health patients as well. And the whole point is about trying to just, you know, ease pressure on secondary care and making sure that we can prioritize and delegate stuff accordingly. General practice, yes, we have to know a little bit about everything, and that's why we are holistic physicians. I also believe in Pakistan, it might be, Dr. Hina mentioned this in her talk, that, you know, remote sectors, we can access, you know, these people can access the same quality of service that is accessible in the private sector as well. And I think it's very, very, very difficult in Pakistan at the moment. I don't know how much hard work has gone behind the scenes. I have heard some stuff, but I can't imagine that this has been, you know, established, you know, just with less sweat and hard work. Because number one, to get through that, you know, this is good enough. You don't have to be a specialist, you know, to access care. Secondly, I think it's also important that general physicians and people know that we do not only deal with your illnesses and your problems and your symptoms, we also deal with, you know, who lives with you, your social aspect of care, holistically, you know, like OT, physiotherapy, all that stuff. But I am not quite sure what is the framework in Pakistan for that. During COVID, we've done a lot of video consultations as well. And in video consultations, we've had our electronic systems have had the facility to ask for photographs. We've directly, like, you know, even on our phones, we've done FaceTime, we've done WhatsApp videos, and we were quite surprised that we could handle a lot of stuff just on the phone and the video rather than asking patients to come in. Some patients sometimes just come in for a chat, which can easily be done on the phone as well. Urban settings, I guess, would be much easier to facilitate this because, you know, you have got the systems, you've got computers and all of that. Rural settings, I guess, the government would have to be involved. In Pakistan, I don't have much knowledge about that, so I can't comment on that. But certainly, I think there is a huge need for even people who are working there for years and years and years to be trained. You know, that it's not just about, yes, what is your problem? That's the diagnosis, that's your medicine, and there you go. Health promotion, I think, is a big thing that needs to be part of the system as well, because then you can actually, you know, reduce chronic disease load as well. So those are a couple of things that I think I had in my mind when I was going through these questions.
Thank you, Dr. Tahira Salim. That was nice of you. And then we have our next panelist here on the list is Dr. Unab Khan, Associate Professor and Chair, Department of Family Medicine, Aga Khan University Medical College, Pakistan. Welcome, Dr. Unab Khan. So the next question is from Dr. Hina Jawaid, is about the telemedicine, how it has postgraduate teaching in family medicine changed using telemedicine in COVID-19 times.
Sure. Assalamu alaikum. Assalamu alaikum, everyone, and thank you for having me. So just quickly, I'm Onab Khan. I'm an AKU alum and then moved to the US for many, many years and was working in family medicine and trained in family medicine and adolescent medicine and was working in New York. And then lastly at Brown, and then 2 years ago moved back to AKU, to my alma mater. It's nice to be back in Pakistan at times when it's desperately needed to be here. I think, you know, I've been lucky that family medicine has been, you know, part of AKU and its ethos from the very beginning since I was a student. So we get family medicine as undergraduates in year 3, year 5. Everybody has a flavor of what it is all about. And I think that is what has interested a lot of us to go into this specialty and recognizing it as a specialty in its own way, because it does allow us to learn a lot about many, many things. But at the same time teaches us how to be connected to a patient in a very different way, right? I mean, it's not just about the disease, it's about the patient. So that patient-centered concept is really a very family medicine concept, I think. So, so I think what I'd like to talk about today is how telemedicine has moved away. How is it working in a private sector? Because, you know, as Dr. Ijaz was talking about, it's one in, it takes a lot of effort in the public sector to do it, but what we do is for free and it can be subsidized. But in the private sector, when a lot of the doctors have to make their living, and if the patient is not coming, how do you charge your patient? How do you continue your own life and your economy, your home economy, while you're taking care of patients during COVID? And I think the private sector has really been very nimble in picking this up in Pakistan. People recognize that this has been a need for a very long time. And I think COVID has just pushed us all to do it really quickly and rapidly. So at AKU, we've taken telemedicine very seriously, because I think in big hospitals, the patient population and the census went down by 30% to 40% because people were scared, and rightfully so, to come to a hospital. We've moved to charging people using Jazz Cash and Easy Pesas and what have you, whatever they can. We have our collection points all over Pakistan, so people come to a collection point and pay the money for their appointment. And then we connect with them in every which way portal that they like to. So it could be Zoom, it could be WhatsApp, it could be just a video chat, it could be an audio chat. And I think it's important because in Pakistan, in many ways, because we don't have regulations, it puts us at risk. But at the same time, because there aren't very stringent regulations, you can go ahead and explore different opportunities. And I think that's what this has allowed us to do. So I now see patients from Pakistan, from Karachi to Gilgit on a pretty regular basis. I have patients calling in from UAE, some people calling in from, you know, completely different countries, from Saudi, who can't access care because they're stuck or quarantined or isolated in their own areas. So it's been a lot of fun. Talking about residents, so we have the largest residency program in family medicine in Pakistan. We could take about 24 residents at any given point. Teaching them how to, again, connect with your patient when you can't actually touch them has been a really interesting thing, right? Because we do so much of our understanding with the patient by holding their hand or by saying, I understand, and now you can't do that. So how do you actually create that same aura with your patient? Has been interesting. So the way we've been doing it is that in our clinical settings, we would have our resident first, we all have to wear our masks. So first of all, telling a patient, I'm wearing a mask because I'm sitting next to somebody else who's very close to me. So you can't see me, but know that I'm hearing you and I'm listening to you. So your body language has to change now compared to what you used to before, because you've got your mask on. And then we usually try and do as much video chat as we can. The resident will take the first part of the history. I'll sit next to them so that we're not wasting too much of the patient's time. And then they, and so we kind of swivel the laptop between the two of us, or the webcam between the two of us, so the patient knows that we're both hearing them and listening to them. And then, even though I can't do an examination, a lot of it is, luckily in Pakistan, people don't live alone. People have a family or a relative sitting with them. You can say, can you just move their knee if somebody has knee pain, right? And you could do a straight leg raise for me if somebody has back pain. And I can't see your throat, but somebody can touch and you can tell me if you have maxillary pain or facial pressure. So things like that. So other than dealing with COVID, we're taking care of pretty much everything under the sun. We're doing a lot of dermatology. We're doing a lot of musculoskeletal work, which is part and parcel of what a lot of us in family medicine does. And the residents are loving it. They're just thriving with this one new way of connecting with patients. and learning how to do it. So I think it's been a great, interesting experience, but a great experience for all of us. And I think, again, as what Dr. Tahira was saying, I think access to care is going to improve so much if we do this and we take this on. But I think on the private sector, knowing how to do it in a way where you can sustain it and you can get paid for the work that you do is important, because otherwise most of us won't be able to do this. So.
Thank you so much, Dr. Nab. Thank you for shedding the light how the family medicine is, or telemedicine is introducing new ways of learning for patients and physicians all over the world. And especially with mental health patients, when you're talking to them, it takes longer time, and to satisfy them, it takes a hell of time for family physicians to satisfy them. But it's a great learning curve for all of us. So next, I'm not sure Dr. Nasir is back now with us or not. If Dr. Nasir, if you're there, are you listening or not? I don't see him anywhere. So next is Dr. Babar Rao is with us from US. He's a dermatologist and he's also doing lots of telemedicine here in US. And if he wants to shed some light on telemedicine in US, Dr. Babar Rao.
I think he also just left. I
Okay.
see his picture. He, I think, had to leave a little bit. So,
okay. So we have lots of questions coming up from our attendees now. So I have a question about, and that is, I think, a very valid question, and how to deal with record keeping and patient confidentiality. So I would like to ask Dr. Hina Jawaid if she wants to shed some light on this for record keeping and keeping the patient confidentiality and medical legal aspect of telemedicine. Dr. Hina Jawaid. Anyone else who would like to talk about? Oh, you're back now. Okay, thank you. So the question is about the medical legal aspect of telemedicine and how to maintain patient confidentiality and record keeping.
Right. As I said, we have got paper-based documents at the moment, and they go into a particular room, and only limited people have access to the room. We ensure our best. There are notes written all over the telemedicine center about patient confidentiality and privacy and stuff like that. So the maximum that we can offer, we are trying our best to do. The access to data is difficult. And I'll give you an example that even the faculty is denied access at times. So our end, we have ensured everything. Obviously, there are process and procedures at the university level. And because it's a government-owned data, so government will be taking over it at some point. So access to data is really, really difficult, as I said, even for the faculty. So, but we haven't got any, we are trying to move the documentation to electronic. So our IT teams are involved in it. But again, everything is in infancy and very early stage at the moment. We develop protocols and standard operating procedures as we proceed. They were non-formed at the beginning, but there are moments. I hope that answers the question.
Thank you. So Dr. Babar Rao is back now. Welcome, Dr. Babar Rao. So he's a dermatologist, very busy practice, and he's working, I think he's doing lots of telemedicine here in the US. So would you like to shed some light on telemedicine?
Thank you. And it was a good presentation by Hina. She made it very crisp and organized what they have done. Actually, talking about telemedicine, in between, I got a text from Vice Chancellor of PIMS. He has a skin patient. I need to see it right now. So I jumped that way and replied to him. But anyway, so I think he had four questions there. One of them was about patient confidentiality, which somebody just, which she explained. But ultimately, if we're gonna do telemedicine for masses in Pakistan, it has to be electronic medical record. There is no other way, because the reason for that is also then, because these patients are not really, you don't have access to them all the time. If you want to contact them, if you want to research or implement treatments, then it has to be electronic medical record in the long run. And in reference to training, her last question was training, which already Hina And Shahid, through APPNA MERIT, I'm part of his team. They have already started many initiatives. So some in Pakistan are already happening, and then through APPNA they are doing. So I think trainings are on their way for family medicine, which is good. And then to me, really, COVID happened, and obviously it's a difficult thing for, especially for poor countries like ours. But I think if there is COVID every day in Pindi Medical College outpatient, or in Dow Medical College outpatient, or in the Nister Medical. If you go to any outpatient any given day, there are about 500 to 900 people standing, and you just see heads by the time you get to who are you going to see. So the solution is like public sector, like Unab were talking, or then from the government side, both together. Ultimately, we have to reduce the number of patients walking or coming to outpatient departments. And if we can hold most of them or many of them without coming to the hospital, then I think that will solve a lot of the issues. And the solution is humanistically, like the number of doctors we have, we can just do it in Pakistan. So we have, tele has to be solution. And I see that now government is interested and public sector is interested. And there are many companies like from Sehat Kahani to this one through Suhail and Aga Khan. So eventually the solution will be telemedicine to provide healthcare in Pakistan to the masses, not to just some. And eventually, yes, like this prime minister or a new prime minister or a governor or all of them have to get together and basically work, with public sector to work on tele. That's just my comment. Yeah.
Thank you, Dr. Rao. We have a question from one of the attendees, and he's asking, has some work been done to set the limitations for telemedicine consultancies? Please share updates. So, Dr. Unab, would you like to answer this question?
Sure. So yeah, it is difficult to see all patients on telemedicine. I don't think everything can be seen on it. So there are certain limitations. So for example, if somebody has a sore throat, I can't always look inside their throat. And I hate giving antibiotics without actually making sure somebody has strep or not. So that is one place where we do find it. You can't do auscultation. So if somebody has a rhythm problem, I really can't see whether they are in AFib or not, or if they're having palpitations, what does that mean? So I think auscultation is one thing which you really cannot do, and you can't ask a person to do it for you. What we started doing at Aga Khan is that because we have home health services, one of the nurse will go to the patient's house, and the nurse can tell me more than what a layman or a family member can always tell me. Right. So if a nurse can do their vitals right there and then and tell me in auscultation periods, hey, this is somebody in pulmonary edema, that helps me a lot. But if we can't do that, then I do tell them that this is something that I really don't think we should try and do just on telemedicine, and you should come in and get seen and come to a safe place, wear a mask coming in, and we'll make sure that you're taken care of safely also. So I think, whenever there is auscultation required, I think that's where it becomes a problem. In younger kids with infectious diseases, I know that auscultation is not always necessary for pneumonia. We do it all the time with just listening to the respiratory rate and counting it using our WHO protocols. But I think for older people, that becomes an issue. Geriatric services we found are really, really amazing on telemedicine. Patients love it because they don't have to leave their houses. And so the same for palliative care. I think we're doing a lot of that also, and mental health, of course.
Sure, we have certain limitations by working on telemedicine, but as Dr. Rao said, that we have to limit influx of patients who don't need to come in, and we have to screen them on our phones who needs to be seen in our practice. There's a question from Dr. Samina Hijab. So she directed this question to Dr. Hina Jawaid. Can you tell us what will be the cost of setting up telehealth for one office? Would there be a teaching training session for the telehealth?
Good question. I don't have a clue because board in but people who have
I can answer, yeah.
Yes.
So
tonight, but
I think as I mentioned, you can actually do telemedicine use. Yeah. Sorry, I was answering about the cost. If you allow me, Fizza.
Dr. Hina, I can't hear you now. Hello? I think, yes.
Yeah, Dr. Babar can, if
yeah,
anybody.
Yeah, you can.
So what I was saying is like, really, there is not much cost anymore because as Unab was mentioning, you can do it via, obviously, by any cell phone or iPad or any desktop in your office. And you can use Zoom or many other services now, even in Pakistan, available. So cost is almost minimum. It's just like you have to have a doctor who's on this end and a patient just to teach him how to use his cell phone. So cost can be as low as $20 in America. I know we have many services. You just pay $20 per month. Or I know in Pakistan, there are services, I think they could be even cheaper than that. Only thing is patients, how would they contact you? So they have to have something on their phone, such as, we do some teleservices in Africa and we only use WhatsApp and WhatsApp video. And this is through American Academy of Dermatology. And we're doing tele through WhatsApp. So it could be almost really free or almost very cheap. So cost is not an issue. Training, how to train your doctor, that's a different issue. Yeah.
I think the bigger cost actually comes not in the cost of being able to communicate with the patient and that portal, but more about how to keep your records confidential. So having that electronic health record or a way of you being able to keep paper records and building up a health record system, I think that's a bigger thing for Pakistan because people in private practice don't always think about it. You know, you आप पर्ची पे लिख देते हैं and you say कि अगली दफा यही पर्ची लेकर आ जाना, and that is just not on because a lot of this has to be done documented well and being able to somebody to be able to audit it later on to ensure that you're providing good quality care and for medical legal purposes also. So I think that documentation is where the cost is going to come in Pakistan. I don't think it's a virtual platform which we need.
Yeah. Thank you so much for your input. And I think Professor Nasir Shah is back now with us. Professor Nasir Shah, as most of us, we know he's a big name for family medicine in Pakistan. He's MCPS, FCPS, MRCGP, FRCGP, professor and head of Department of Family Medicine, University of Health Sciences, Lahore, Dean Family Medicine Faculty, College of Physicians and Surgeons, Pakistan, Convener, National Family Medicine Committee of Pakistan. So, Assalamu alaikum, Dr. Nasir Shah.
Walaikum salam. First of all, I will apologize because I lost all 3 of my net connections at home. Then I took my car and drove to my office and climbed 4th floor, and now I'm in my office just to connect. Sorry for that. I missed a lot of the stuff. I just joined.
So welcome back. We are not finished yet, and we would like your input about family medicine. And as you know, you're training so many students, and especially from Canada. I have seen lots of your trainees here who are working already. And Fatma Memorial is becoming a hub of family medicine in Lahore because of all your efforts, mashallah, great work. And we are hoping APPNA MERIT has great initiative of starting this family medicine. And we are hoping all of us can work together and can bring family medicine back in Pakistan as a backbone of our health system. Yeah, so we have talked about telemedicine and role of family physicians. We would like to have your comments on it.
Yeah, first I will start with the most recent question, the cost. Like Dr. Babar said, cost could be negligible. If you just want to communicate, you can use any of the free available gadgets. Just like Dr. Unab said, the software cost is there, and the mode of payment that also increases the cost if you want to connect it with a bank. Another thing is the model that hub and spoke model, where you want to use gadgets like pulse oximeter, digital stethoscopes, the cameras, the BP apparatus, this thing. That additional cost would be there if you use hub and spoke model. For this simple method, which we use in lockdowns, cost is minimal. The other point, like family medicine, it's just a replica of the real life telemedicine. Both specialists and family physicians, they use telemedicine. And the same referral system could exist in this as well. Like a first line, we sit there with our own patients, and then those who need referral, we can even arrange referral through these telemedicine services. So this is I think the electronic version of the real life. I take it like that is simple. The other point is like family medicine, telemedicine in Pakistan, the experiment Dr. Hina has mentioned, if you have a journalist all the time present, the satisfaction level increases a lot. That was why the other people, they have patchy. They have once they have a pediatrician, once they have an internal medicine. So they need a big team to give a satisfactory advice. But if they have one or two trained family physicians, the satisfaction of the patients increases a lot. And that's it.
Thank you. I see Dr. Sadia Khan has raised her hand quite a while ago. So Dr. Sadia Khan, if you could unmute yourself, I unmuted you here as well. If you want to ask your question. Dr. Sadia Khan.
Hello, can you hear me?
Yes, we can.
Okay, it was an excellent presentation by Dr. Hina Jawaid, and she rightly said that family medicine specialists are the ones who should be running and supervising telemedicine. And as Dr. Nasir pointed out, that if you need a whole team of specialists to run a telemedicine center, if you would like to specialists to come in and run it, but with family medicine, you only need one expert and he will run the show for you. So that is excellent. And that is a landmark achievement that Dr. Hina Jawaid has achieved. And I hope and really, pray that this model is replicated in other provinces of Pakistan as well. So hopefully, I'd like to know what initiatives have been taken by, for example, in Islamabad, as Dr. Baba Rao has just contacted the Vice Chancellor of PIMS. Would he be interested in having this model replicated in Islamabad, for example, as the capital city?
Should I answer, Fizza, or?
Yes, sure, Dr.
Yeah.
Baba Rao. Go ahead.
Okay. Yeah, so we know two vice chancellors in Pindi and Rawalpindi Medical University and PIMS. They're both our college mates, me and Shahid from Pindi Medical College. And I know that Rawalpindi VC is already working on similar model to what Hina presented, very similar. And PIMS, Khalik, I can talk to him, but I'm sure if we, the way it works there, as you all know, if let's say Unab, Hina, Shahid, or me, or Fizza, or anybody, tell them, okay, this is what we want to do, they will say, okay, do it, and then let's see how we help you. So if I talk to them, I'm pretty sure he's gonna give me and Shahid the project, okay, set it up or something. But I think he'll be interested, yeah.
Well, I'm located very close to PIMS, and I can go and offer my help in COVID situation. So if he is receptive, then I'd very much like to go and initiate this project.
So,
okay, I will talk to him, yeah.
Yeah, this is Shahid also. Sadia, if you can please give us your email or contact information on this chat privately to me, and then we can connect so that we can see what last I heard from Islamabad was that there was also a plan to involve Indus in the federal territory, federal area basic health units. And I do not know the detail and authenticity of that information, but I think there are many different ways and different ideas that are cooking in Islamabad territory. Dr. Zafar Mirza had one basic health unit as a model unit as well when we talked to him last in March, just before the COVID around our conference. So it would be interesting. I'm sure I think what our conference did was already what Dr. Nasir Shah and Hina and Dr. Naab and leadership of family practice in Pakistan was already doing. Maybe we just put a more spotlight on their effort, and maybe bring all of us together. Even Australia and UK is very interested in, so whatever role we can play. Obviously the main role is for the leadership in Pakistan, such as Dr. Naab and Dr. Nasir Shah, Hina Jawaid and others. But I think we are interested to see wherever merit or telemedicine or in any way we can help. So I would encourage you to share your contact with us. Tanveer Khalik is my class fellow, who's the VC of Shahid Zulfikar Ali Bhutto University at this point. So we can talk to them, and we can talk to Dr. Umar, who was also an alumni.
So I can also give you an update from Sindh that the Jinnah Sindh Medical University is also doing telemedicine over here in the public sector. And Aga Khan, we've been doing telemedicine with Gilgit, Baltistan and Chitral for mental health issues for many, many years. And we've been doing actually surgery telemedicine over there also, because when somebody has an acute abdomen or somebody has a thing that doctors over there need somebody to consult with, so the specialists from AKU then consult with them directly. And during this COVID, AKU has trained, I think the goal was with Dr. Zafar Mirza to get about 100,000 people trained, and even things like infectious diseases, like infection control practices, donning and doffing of PPE. So a lot of work has happened, not just in telemedicine to patient-related work, but even training of doctors and healthcare personnel in how to take care of themselves. So I think this has been a huge achievement for the entire country and what we've all been able to do together to make this move forward.
While we are on that topic, I would ask both Dr. Nasir Shah and Dr. Unab, in their experience, recent experience, I think, do you think that that the issue when we were in Pakistan and young graduate many, many years ago, one of the issue was that, if you are posted by the Punjab Public Service Commission or Federal Public Service Commission to a remote area in a basic health unit where you cannot even reach on a decent road, and so most people who were living in cities and were appointed to go to a rural basic health unit were reluctant to do that, and that's why they did the FCPS in other specialities or went outside Pakistan. But with this telemedicine, I see personally a theoretical potential to have the group of family practitioners in a city like Lahore and Karachi, while serving the interior Sindh and interior Punjab or southern Punjab, and maybe having, what do you think, advanced nurse practitioner or advanced physician assistant to do all that pulse oximetry or point of care testing or blood pressure or whatever it is, and then report to you and be part of your, so that is similar to what I do here, like telestroke. I'm a stroke specialist, so a lot of places do not have neurologists here in the United States also. Or if they have one or two neurologists in a small city or a town, they do not want to cover the hospital for 24/7 coverage, which is required for TPA. So that is why telestroke is a big thing in the United States, and we do that. And so similar model, I think, can evolve or is evolving. It's a comment for you and Dr. Nasir Shah.
Nasir, do you want to take that first?
It's up to you. If you want to start, then I can add.
I can.
It's up to you.
Sure. Thank you. So I think you're absolutely right. We've been doing a lot of now tele-ICU care has started at AKU. We have been doing it not just for, we were doing it for a lot of government hospitals now, because for COVID related work, not a lot of public sector hospitals have the kind of personnel who can do ICU work. So ventilators are there, but people don't know how to always use them. So we've been providing tele-ICU services, and actually a lot of AKU alumni are helping us from the US and being able to connect and do that. So I think COVID has been a huge global medicine platform for all of us. Now, as far as the part of having a nurse practitioner model over here, we've been exploring that. We've been working very, very closely with the government, because the Pakistan Nursing Council has to first of all agree to have an APRN model. But I think task shifting is something that we've been doing in Pakistan for many years. We've had the LHV system, we've had the community health worker system in our rural settings. So I think task shifting and having masters and better trained nurses who can do a lot of the work is what we're doing in home healthcare services within the urban areas, but we can certainly take it to rural areas also. So that is something that we are really working on in the background, that how do we shift, because we will never have enough healthcare people to go to all of these places, but we can certainly have train the nurses who are from that area or the doctors from that area, and then provide them support remotely through telemedicine, as we're doing in Gilgit right now. So that's what we're hoping to do and continue to expand further if we can, inshallah.
Dr. Nasir Shah?
Yeah, okay. Thank you, Dr. Nab. This does not seem to be a very simple question to me. There are many facets of this scenario, like a BHU, the staffing of the BHU, the having a second tier of healthcare provider, which is just below the family physicians. You can call it nurses, nurse practitioner, physician assistant. Previously, we used to have licentiate medical practitioners in the rural setups. They were the second line doctors. They were called doctors. They were very good people. And the other is a distance education of these doctors while sitting in BHU. And the fourth aspect is the telehealth, like specialists in the main cities, and then they provide expert opinion to the rural areas. So there are many facets to this question. If we want to, like we can take them one by one. Like BHUs, they do need some, at least a doctor to make some decisions, to make safe decisions. If you leave these places at the mercy of people who are not doctors, who have not gone through extensive trainings, sometimes they make decisions like epigastric burning, epigastric pain. They can miss it. It may be MI. So, because for safety reason, we need to have a trained doctor. Currently, we do not have trained doctors. Even if they are posted, they are fresh graduates without any training. But so we have proposed to government of Punjab is to have an induction training, maybe a 1 month or 2 months intensive residential training about common problems, emergencies, differential diagnosis, lab interpretation before going into the peripheries. And once they go into the peripheries, they can have periodic continuing medical education sessions, maybe weekly, maybe monthly, so that when they spend 1 year or 2 years time, they at least know the primary healthcare system. They are safe and competent, and we can complement their services by specialist opinions from the major cities. Ideally, if you follow the actual district health system of Pakistan, it was made very beautifully, wisely. The tertiary care hospital is the apex of the system. DHQ, THQ, and they are all connected. Now the tertiary care are not connected. Like the system does not have a beheaded system. So if it is the responsibility of the tertiary care to cater to the needs, educational needs of all the staff of that division, there's one medical college in each division. So they are not connected. We can revive their connections. Distance learning, we have been doing it for 16 years, for 15 years now. So works very well, even from Lahore, third district, and Chitral, Gilgit. This is a successful model. We don't have to reinvent it. We have even done through DVDs and CDs, and they also work. Whatever method you choose, distance learning works if there's a desire to learn at the other end. In the scenario of Punjab is slightly different from other provinces. In Punjab, all the doctors who wish to go into post graduation, be it FCPS or MD, they must spend at least 1 year in the BHU, RHC, or periphery, and that is a mandatory rotation. I call, because they don't want to go to peripheries; they are forced to go there. It's by force. So what they do is they study there for FCPS part 1, for USMLE, anything. The packages are good. The salary of a fresh graduate is more than an associate professor or a professor of a tertiary care hospital. They get money. They don't have to do anything. The dispensers are doing everything. So it is not working. Even having a doctor there, because he's not trained, he does not want to work there. It's by force. So we will suggest to government that give them a career in the same setup. So they learn family medicine, they do diplomas and masters through flexible trainings. So there are many things in this scenario. It's a if we combine everything, it's a win-win situation.
Yeah, we have many questions coming up, and we are running short of time here. And I know there's lots of interest about family medicine from everywhere. The most important question I think will be the last question, but we can answer the question in the question answer session later, or we can have another session later on. This is a question from one of the attendees, whether all the specialties are ready to accept family medicine as another specialty, and are they willing to give their private patients to them also? And this is a burning question, I think, in Pakistan. So whoever wants to answer this question, Dr. Unab, what would you like to say about this?
No, I think just before this webinar started, we were talking about the fact that, you know, what drives a specialty towards a specialty, and it's the economic payment system, right? Unless and until you have a healthcare system which is publicly funded, or a healthcare system which wants to see a cost-effective reason to provide care, we would not be able to be successful with family medicine, right? Because we are then the ones who can take away everybody's patients. Because we can most of the time provide better communication skills at least, and can take care of the entire family at one time in time. So people are actually, a lot of specialists are actually quite threatened. But also I've been able to find amazing support from some of the specialists who are very mature and who are very secure in their own work. And they recognize that the more they give me all the little stuff, the more interesting cases they would get. So, you know, not every cardiologist wants to see every hypertensive patient. They would rather that we saw the hypertensive and send them the ones who need Holters and the ones who need angiographies and things like that. So I think hopefully as time goes on and people see that we don't want to take away their practice, but actually give them more fulfilling practices and more things where they can use their specialty in a better way, they'll be less threatened by us. But it's going to take us a little while.
I understand that. I think the more, I'm very impressed by the way Aga Khan University is working with Gilgit and Baltistan and all those remote areas. And if we are going to showcase our work, and that can be impressive, and this is going to impress our youth, especially that how health system is going to work in Pakistan. And this will be a slow process, but it's eventually is going to work. If our panelists are willing to take a few more questions, we have a few more questions. So otherwise we can finish. Dr. Hina, but you're okay to take one more question?
Yeah,
okay.
I can. Yeah.
So there's another question from one of the attendees. OBGYN needs personal consultations 90% of the time, you know, about our prenatal patients. So telemedicine in Pakistan on individual physician basis is taken care of by pharmaceutical industry and is running very successfully. Audio recordings between patients and provide to prevent medical legal implications can be added to telemedicine. How will this be possible? Are there any ethical implications?
Right. Is it all the same question relating
same question to by one person? Yeah.
Okay. Right. So I know we have been involved in the antenatal care. We get a lot of calls. Like up until now, we have received about 400,000 calls, audio and video. So the number of consultations we have provided through the telemedicine center is 400,000. And we had a significant number of antenatal calls as well, in which family physicians were involved. And to back us up, we had asked for help from obs and gynae consultants as well. And a number of them had provided their numbers and the timings through which we can contact them. So we were very specific when we were telling the patients. In terms of the, as I said, everything that she has mentioned about audio recording, we haven't got any facility for recording our consultations. So you just have to bear with the goodness of the physician's heart that he or she is telling the truth and not lying. We've got very limited documentation when it comes to the papers that are given to our volunteers to write. The space is very much less. I use a lot of space when I'm documenting, probably because I'm trained abroad and I'm used to writing a lot of information because of medical legal implications anyhow. So I don't think any of that has kind of as well developed. So I would not be in a position to answer that. But what the main purpose of this presentation was that we have developed kind of an appetite, given a spotlight to family medicine, and people are now looking at it. The more attention we get, I think the more we'll be in a position to deal with the nitty-gritty and the details that people kind of expect us to answer at this stage. So I think at this stage, we won't be able to answer that question. I'll give you a small example. I was one of the first doctors to start teaching ethics in family medicine in Pakistan, in Lahore region, in Punjab region. I won't talk about the entire country, obviously. My topic was turned down from one of the associations program because they said people don't like to hear about ethics. Now, when we started our faculty development program, ethics, evidence-based medicine, audit and research is one workshop. We are trying to conduct it through Zoom at the moment since the COVID started. The impression I'm getting is not many doctors, general practitioners are kind of aware of it or feel they are out of capacity when dealing with ethical issues. So ethics, again, I'm using the word infancy for it, at the infancy level in Pakistan. It's very premature at the moment. So it will take us a while to get there, provided we have a well-defined.
Fair enough, good answer. And one last question is, how would you define family medicine versus general practice?
Okay. We'll have a huge debate on it. I know Naphan did mention something about it when we were discussing about it last week. General practice is more of a British term, I think, because those who have returned from UK, we like to call ourselves GP. Family medicine is more kind of an American term. And when you come to Pakistan and both terms collide, then I don't know who wins in the end. So I think in Pakistan, they prefer the term family medicine. Even at the government level, they don't like to hear the word GP, because the definition that comes to my mind, or even if you ask the lay person, GP wo doctor hai jo gali mein baithta hai. That is the definition of a GP, if you ask the people. So I think we certainly need to raise our standard in game here, if we want to use it as a synonymous. Yeah. I don't know if Naphan wants to add something.
No, Hina, you're absolutely right. I think, the only reason to use the word family medicine or family physician in Pakistan is because the term GP has been used for the untrained person and sometimes even for the quack, right? So just the understanding of people that you can just do your MBBS and the next day open up your shop is actually a very dangerous one. And our, even from our public sector, from our government, they think that this is okay to do that. And that, aapne 5 saal pad liya, but it just isn't. And so any one of us who's gone and gotten trained in family medicine or general practice understands why that training is so important for us to become good physicians. So I think that the reason to not use the word GP in Pakistan is more because it is already really connected with that person who's untrained. So I think that the training is important, and none of us could be good physicians without being trained further beyond our MBBS. And if that means we call ourselves family physician and family medicine consultants, then why not, right? Because I think it will take a long, long time to make the public think that the word GP means anything else.
Great. Dr. Nasir, any last comments?
This is a very naughty question. I want to answer that.
But very genuine question. We need to raise the level of family medicine, introduce it as like a specialty in Pakistan so people understand what family medicine is. It's not just a GP ship. And Dr. Tahira Salim, any last comments from you? Can't hear you. Yes.
Can you hear me now? Can you hear me
Yeah.
now? Yeah, I was saying, I think it's important. I guess one purpose that these sort of webinars are serving is that, there's more and more people are, getting awareness about these. I myself, I know Dr. Jawaid from quite a few years ago, and she's introduced me to this. So I think the more we spread the word about this, and the more, especially people who are, from Pakistan, based overseas, and if they can provide their services as well, I'm sure we can, take out time from all our lives, to try and invest our experience or our expertise. I think that is what stems to my mind while I'm attending this and hearing from all of you, because I've been out of the country now for 16 years roughly. And though I come regularly, but certainly, I didn't know so much was going on. My experience has very much been limited to Karachi. So from my side, that's what I will do. I will just raise awareness that there are these APPNA Merit webinars. There's APPNA over here who's doing a lot of work in, a UK organization. You guys are well aware of that. That's all that I would say. And just thanks a lot for introducing me to this, Dr. Jawaid.
Thank you. Dr. Ejaz, any last one comment from your side? You've been quiet for a long time.
Yeah, just listening to all good things and becoming wise, just reading to my all good colleagues. One last thing I would like to say is that under the guidance of Dr. Zafar Mirza, it all started when Dr. Shahid Bhai was also there a few months back before the conference in RMC. And the concept of family medicine, or the WHO called it more broadly, there is another term, family practice. So that is also comes in with GP and family medicine. So what the idea is to train the public sector doctors in Islamabad and 5 other districts in provinces, which have been chosen to train the already working GP level doctors to train them at the family medicine level.
Can't hear you anymore, Dr. Ejaz. So I think we should.
Now all the universities which are.
Okay. So thank you very much. We will conclude our session today. I would really like to thank Dr. Hina Jawaid, Dr. Professor Nasir Shah, Dr. Unab Khan, Dr. Tahira Salim, Dr. Ejaz, and Dr. Babar Rao, and Dr. Shahid Khan, who is the chair of APPNA Merit. It was nice to know all of you. We are really excited here at APPNA Merit to start this family medicine. You guys are doing great at Pakistan, and all of you, listening to you, we're all passionate to bring this family medicine in Pakistan. We are here to help out, and whatever services we can provide, we are always here. And thank you, APPNA Merit, for this great session. Nice to talk to all of you, and inshallah, we will be connected. Assalamu alaikum.
Inshallah. Thank you.
Thank you very much. Assalamu alaikum.
Allah Hafiz.
Hafiz.